Next case. 47-year-old male. He had 8 minutes of slurred speech. Got better. Never had anything like this before. Negative non-contrast head CT. Now what? What is this? Right. So we got resolved symptoms, negative non-con head CT. We didn't find anything going on. TIA is the likely diagnosis. What do we do with TIA? It's unstable angina. It's unstable angina of the brain. That's all this is. You didn't quite infarct anything, or else we would have called this a minor stroke that didn't merit TPA. So basically, this is your troponin negative, but brain addition. So TIA is is unstable angina. That's the incorrect slide title. So always give aspirin to both of these folks. Remember, aspirin, really, really beneficial. A lot of people get diagnosed with TIAs, never get their aspirin in the ED. That's a shame. You should give it every time that you have a stroke or stroke-like patient that's not getting lytics. You need to give an aspirin in the ED. Neither of these patients benefit from any sort of TPA at all. There should be no signs of infarction. If you get that MRI and you see that there's infarction, this is not a TIA in my opinion. There's a lot of weird verbiage around this where they say, oh, it's a TIA, but there's a little bit of infarcted tissue. Well, their symptoms got better, but that was just a minor stroke that had the symptoms resolve, in my opinion. There's really, really messy terminology about can you have signs of infarction with the TIA? It really is messy terminology that's sloppy, okay? But there shouldn't be any signs of infarction. And it generally should be hospitalized. There's a way to send people home. It's really hard to do, and I strongly caution you against it. And you're going to modify the risk factors, okay, after you investigate the vasculature. So if these are the people that you have to admit, okay? I don't care where you are. I don't care if you've got a neurologist who wants to see them in 12 hours in their clinic. You have to admit them. They have a treatable cause, okay? If you find something on your workup that says this is the thing that caused it, you have to admit them. If you see any signs of infarction on an MRI, you have to admit them. If you're uncertain that the person can follow up in 2 days, which is essentially every patient I've seen at MCG ever, and the VA for that matter, that's doubly certain at the VA. If you aren't certain that they can be evaluated in the next 24 to 48 hours, you have to admit them. And the AHA guidelines back you up. There's the ABCD2 score. If it's over 2, you got to admit them. And anybody with ischemia, you have to admit them by their guidelines. So let's review this really quick. What's the A? Age, over 60. B. Blood pressure, over 140/90, which is not that high. C. Clinical, right? So they get 2 if they got dense unilateral signs, 1 if it was just speech changes. If they get a 0, it's a little bit weird about why this was a TIA, in my opinion. D, duration. If it's over an hour, this is almost certainly not a true TIA and was probably a small stroke. You see a lot of infarctions on these people when it's over an hour. It's really hard to have something transient where your brain wasn't getting enough blood for over an hour that gets better. It just isn't that common. But if it's over 10 minutes, you get a 1. And then the other D is diabetes. If you're diabetic, you're more likely to get admitted. If you get at least 3 points on this, you have to be admitted. But even if you're low, you have to be able to get follow-up within 48 hours, which is an impossibly hard bar. So you're always going to get imaging. MRI, MRA is probably superior with the DWI if you can. CTA is going to be the real-life thing that you're going to get in a lot of places. So if the imaging shows infarction, it's not really a TIA. It's a minor stroke, in my opinion. The terminology is really messy about where that line gets crossed. If your symptoms totally resolve, then it technically could be considered a TIA. But if you're seeing signs of infarction, it's kind of like calling something unstable angina when they have a positive troponin. It doesn't make a lot of sense. Here's a little 2-step that we often do where they say, oh, we recommend an MRI, and then we'll figure out if they need to be admitted to the hospital or not. That's garbage. That's absolute garbage. Negative imaging with an MRI proves that they didn't infarct any of their brain. So yes, if the MRI is positive, well, guess what, Sherlock? You got to admit them. If it's negative, they still had a TIA if that's what you clinically suspect, which means that unless they can ensure follow-up within 48 hours to get all the stuff that you would admit them for, they should also be admitted. The MRI is not a disposition machine for TIAs. All that you're picking up are TIAs that have a small amount of infarction, which are not really TIAs at all, but tiny strokes. Doesn't make sense. So do not rely on an MRI to tell you who you should admit or not. This is unstable angina of the brain. It should come into the hospital. Really, really risky discharge.